Hi, in this video I'll be talking about adverse reactions associated with red blood cell transfusion and platelet transfusion. Approximate risk per unit of red blood cell transfusion. For febrile non-hemolytic reaction, the risk is 1 in 161. For allergic reaction, the risk is 1 in 345 chance. For transfusion-associated circulatory overload, it is 1 in 125 chance. For transfusion-related acute lung injury, it is 1 in 1250 chance. For anaphylactic reaction, it is 1:5,000 chance. For infection such as hepatitis C, it is 1 in 1,200,000 chance. For risk of HIV infection, it is 1 in 1,600,000. Approximate risk of platelet transfusion related adverse events is measured as rate per platelets transfused. For febrile non-hemolytic reaction, the risk is 1 to 10 per 1,000 platelets transfused. For allergic reaction, it is 10 to 30 per 1,000 platelets transfused. Transfusion-associated circulatory overload, risk is 2.6 per 1,000 platelets transfused. Transfusion-related acute lung injury, risk is 0.03 per 1,000 platelets transfused. Anaphylactic reaction rate is 0.02 per 1,000 platelets transfused. If an adverse reaction is suspected during a transfusion, one should stop the infusion immediately and provide supportive care. Many of the findings associated with transfusion reactions can overlap. For any suspected reaction, the implicated blood product bag along with a blood sample from the patient should be sent to the blood bank for further investigation. Non-infectious acute adverse reactions to blood transfusion. Febrile non-hemolytic transfusion reaction is characterized by temperature increase of 1 degree Celsius or 1.8 degree Fahrenheit within 4 hours of transfusion and is accompanied with chills, rigors, tachypnea, and tachycardia. It is caused by recipient antibodies binding to the white blood cells in the donor blood. This reaction is a diagnosis of exclusion made only after other serious reactions are ruled out. Treatment includes supportive care with antipyretics and transfusion of leuko-reduced blood products in the future. Allergic and anaphylactic transfusion reaction is mediated by IgG antibodies resulting in release of histamine. It is characterized by pruritus, urticaria, wheezing, angioedema, hypotension, and shock. Treatment includes supportive care with antihistamines, bronchodilators, and epinephrine. Washed blood products. Acute hemolytic transfusion reaction is caused by antibody-mediated destruction of red blood cells in a patient, and it is mostly attributed to giving incompatible blood products. These reactions can be acute, occurring in less than 24 hours, or delayed, occurring after 24 hours. This reaction is characterized by fever, chills and rigors, hemolysis, hematuria, acute kidney injury, resulting in disseminated intravascular coagulation. Treatment includes supportive care and transfusion of compatible blood products and maintenance of adequate urine output. Transfusion-associated circulatory overload occurs when blood product infusion leads to iatrogenic cardiogenic pulmonary edema. It is characterized by bilateral pulmonary infiltrates, dyspnea, hypoxemia, tachypnea, tachycardia, jugular venous distension, and peripheral edema. Transfusion-related acute lung injury is defined as non-cardiogenic pulmonary edema, which typically occurs within 6 hours of transfusion. It is caused by antibody-dependent neutrophil activation, resulting in endothelial injury, capillary leakage with exudative fluid extravasation, causing acute lung injury. It is characterized by bilateral pulmonary interstitial infiltrates, dyspnea, hypoxemia, tachycardia, and tachypnea. Non-infectious delayed adverse reactions to blood transfusion. Delayed hemolytic transfusion reaction is due to transfusion of incompatible blood products, resulting in fever, chills, jaundice, anemia. Treatment includes supportive care and transfusion of compatible blood products. Alloimmunization occurs when antigen-negative patients are transfused with antigen-positive blood products. It occurs when there is difficulty obtaining compatible blood products. This results in production of antibodies against the foreign antigen, resulting in hemolysis. Treatment includes supportive care with restrictive transfusion strategy and transfusion of compatible blood products. Transfusion-associated graft versus host disease is a rare but fatal complication. It results from donor lymphocytes targeting the recipient tissues. Patients at high risk for transfusion-associated graft versus host disease are typically severely immunocompromised, example bone marrow transplant recipients. It is characterized by fever, rash, nausea, vomiting, pancytopenia, liver dysfunction, and death. It usually occurs 5 to 10 days of transfusion. Transfusion-associated infection. Aside from bacterial contamination of the blood products, blood-borne infectious organisms can be transmitted by blood transfusion. Patients who donate blood have their blood tested for a variety of infectious agents. There are small but real risks of transfusion-associated infections. Septic reaction. Sepsis from transfusion is attributed to bacterial growth in the blood product. Platelets have high rates of bacterial contamination compared to red blood cell transfusion. It is most commonly associated with skin flora such as Staphylococcus and Streptococcus. Symptoms typically occur within 24 hours of transfusion and is characterized by fever associated with chills and rigors. To confidently diagnose a septic reaction, the implicated blood product should have the same microorganism isolated from the patient's blood sample. Rapid initiation of empiric antimicrobial therapy involving broad-spectrum antibiotics is recommended.